Welcome to Pennsylvania Newsmakers, and as always, thanks for watching. Well, healthcare is center stage, and we're going to have a little discussion about doctors, patients, and the Affordable Care Act. But first, we're going to look at a concept called medical home care. How important is that to you? We'll deal with that and more after these words.
This is Pennsylvania Newsmakers, a fast-paced, unrehearsed weekly discussion with and about the leaders who shape your world. And now, here's your host, Terry Madonna.
Hi, welcome back to the program. Well, I'll tell you what, you can't open a newspaper, turn on a television, listen to a radio station, and not have healthcare news be front and center, be very prominent, whether we're talking about the Affordable Care Act, its implementation. A little later in the program, we're going to get into the whole business of what will this do to the personal relationship that you have with your physician. How are physicians reacting? We have two doctors now, but we're going to talk about a little different concept, something known as the medical home concept. Joining me, as often is the case, he's the Senior Medical Director from Highmark, Dr. Andrew Bloschichak, and Paul Conslato. Did I get that right? Conslato. Perfect, yeah, I'm Italian, right? You talk?
Yes,
we can do that. Dr. Conslato is a medical director at the Lancaster General Hospital. He heads the physician group there. All right, doctors, let's start with this general discussion. One of the things that I think a lot of people are very concerned about is this relationship with their doctor. I'm going to get into that in greater detail in a moment with a gentleman from the Pennsylvania Medical Society. But you talk about something known as the medical home concept, right?
Correct.
How important is, well, first of all, talk about what it is.
Sure. I'll start if you don't mind, Paul. And then,
please.
Medical home concept has actually been around for a number of years. But in the last few years, it's really taken hold. And it's the concept of taking accountability for the patient, once again, in primary care practice. Taking accountability for the patient when they're in your office, but also the population of patients you care for. More open access, more communication with the specialists, almost like we used to practice, if you would. And at Highmark, we've developed a program that incents the medical home. So there's an incentive built into the program when patients are cared for by practitioners in a medical home, such as Dr. Conslato's.
Now, the home you're talking about is a figurative home, right?
Correct.
It's not, you don't go to an assisted living house, you're smiling, but you got to be careful of these concepts.
We've heard that.
So, okay. So let's go from what we've just heard to, you're a practicing physician. What does that mean? I come in to see you, and let's say, who cares what the problem is? How would the parts of that work?
What a patient sees is the difference. It's the way we deliver health care to our patients. That has changed. And some of the key tenets that we've now hardwired into how we deliver care and how we interface with our patients with this medical home construct is around a more coordinated, comprehensive approach. What the patient sees is the team is different. I think anyone would agree that healthcare today in some areas, but clearly yesterday, the team was the physician. And the physician was the orchestrator and the implementer of a person's healthcare. And the relationship was a patient and a physician. And there were a lot of good things about that, but there were a lot of inherent limitations.
Sure.
Only so much can get done.
Yeah, asking the doctor to be all things to all people go ahead.
And as the needs of our community evolved, as we got more sophisticated about our need to deliver a higher level of outcomes, patient engagement, and understanding care costs, we needed to expand and enhance the team.
Yeah.
So what the patient sees is the team is now interfacing with the patient, our clinical staff, our care managers, our behavioral health counselors. The team has expanded under the accountability and the authority of that physician, but the team now accountable to that patient has evolved, has been enhanced, has expanded, so hopefully we're delivering a better product.
I think
Go ahead.
A good example of how that works, Terry, is whether Dr. Conslato's office is using their electronic health record or data that they receive from us as an insurer, they're able to identify patients with maybe some care gaps. Who hasn't had their colonoscopy? Who hasn't had their mammogram? And when that patient comes to the practice or is called to the practice, even before that patient enters the practice, Dr. Conslato's team is, quote, huddling and determining, okay, when Mrs. Smith comes in, we have to make sure she has an order to get her mammogram, colonoscopy, et cetera, as well as how she's feeling that day.
Right. And it's much more comprehensive. I don't know if I'd use the word sophisticated, but you know, when you go in now, there's so many tests and so many aspects to it that when I started seeing a doctor, that wasn't the case. And so basically, it's managing all those parts, if I got this right, making sure that it's integrated, right? That everybody is on the same page, it's integrated. And so this is so obviously so much better for your patients. Why would it not be?
It is, and we're hearing, and part of this is the connectivity with our patients that we're constantly surveying and asking our patients with the changes that we've made. Is it working for you? And at least we're hearing from our patients in large part that they're surprised, but yet pleasantly surprised when they come in with a sprained ankle and a team member's asking them about a mammogram or a flu shot.
Yeah, we're going to run to a break. We're going to continue. I also noticed, because I'm in your health system, I get all these updates online, and not everybody can do that, but I love getting all this information, and I have an understanding about what's going on. That's a real improvement. All right, this is an important concept. We're going to continue talking about it, and then we're going to doctor insurance, coverage, patient relationship, a very important topic given what's going on with the debate over the Affordable Care Act. We'll be back in a moment.
This broadcast of Pennsylvania Newsmakers is presented by the Pennsylvania Chamber of Business and Industry, the statewide voice of business, and by the Pennsylvania Business Council Education Foundation, educating citizens and business leaders about important public policy issues and civic affairs. This broadcast of Pennsylvania Newsmakers is brought to you by BetterSaferRoads.com. To voice your support for safer highways and less traffic congestion, visit BetterSaferRoads.com. And by the Pennsylvania Manufacturers Association. Business in Pennsylvania is our business.
Hi, welcome back to the program. We're having an interesting discussion about something called medical home concept. We're getting into the details of it, about how this is really changing the nature of how physicians treat patients. Do I got that right?
I think so.
Okay, well, you guys have to tell me. You're the experts on this. All right, we're talking also about, we at the break, cost saving?
Yes. You know, we by the way, the medical home concept in central Pennsylvania has grown like wildfire. We now have, Highmark has about 150,000 patients who are being cared for in a medical home situation and practices. We have about 1,000 practitioners, and we monitor the quality metrics as well as costs. The quality metrics, like we talked before, mammograms, colonoscopies, et cetera. But we also monitor the cost for those patients. And we found that in the first year, there's been a decrease, a 3% decrease in their care cost trends compared to the rest of central Pennsylvania, which is about a $24 million savings in 1 year.
Now, is that because it's more efficient? Is it because you're doing it better? You know, all the parts are moving in the right direction, therefore you're doing it better. I mean, another way to ask that question is improvements in your practice, I guess. That's another way to put it.
And to your point, Terry, it's efficiencies and understanding and using data to understand where there's wasteful utilization. And we know in Lancaster General Health Physicians, and we have some key areas that we've been successful at understanding and mitigating and reducing for our patients around ED utilization. And that gets back to appropriate access into our primary care practices to avoid the sore throats and the sinus infections, getting into the ED, higher level of care. Readmissions, being able to assist a patient with our hospital colleagues to transition smoothly back into the community. We know there's a lot of bumps along the road. If that patient's readmitted, if there's not true coordination in that care, that costs money. Generic dispensing rates, where most of the literature would say that a generic drug is pretty equivalent in efficacy to a brand drug.
Has to go through the same approval ratings, right,
Yeah,
by the federal government.
So when you look at those areas where there could be wasteful utilization, let's try to understand that at the same time where our patients are saying, boy, that's an area we'd love for you to help us avoid ED utilization readmissions.
Where's this going?
I think it's going to continue to grow. And you know, having Dr. Conslato here, of all of our practices in all of our network, Western Pennsylvania, Central Pennsylvania, the Lancaster General Hospital Medical Group has done the best in our medical home scoring and patient satisfaction's there. We as an insurer are going to start to develop health insurance products that if you're seen at a medical home, you'll have lesser co-pays, et cetera. That's on the books now because we can show that there's improvements in quality and cost savings.
Right. Well, I have to fess up. I'm in Lancaster. I live in Lancaster. F&M, my college is there. I go to his hospital. I have a physician in there, so I have to fess up. And I like this change. I like this change, by the way. I mean, I have to be neutral here, but it's worked for me. All right. What do you see in your practice in terms of whether you're going to? Is this here to stay?
This is here to stay. It will continually evolve. We're not done. The medical home concept will only evolve. It's a point in time. We've learned a lot over these past 2 years working with payers, changing the reimbursement model to align these incentives better. We're not done. We've got work to do, but I think it puts us on a much better trajectory, understanding outcomes, understanding care costs, and making sure that we keep the patient in the center at all times.
All right, this is a wonderful program. We'll have you back and you can update us on how it's working. All right, we're going to have the president of the Pennsylvania Medical Society on next. We're going to talk about Medicaid expansion, how this is affecting doctors. Folks like their family doctors. I personally have done polls on this. They like the healthcare system. How is this all changing? We'll find out from the president of the Pennsylvania Medical Society in a moment.
This broadcast of Pennsylvania Newsmakers is brought to you by Pennsylvania Credit Union Association. Pennsylvania Credit Unions, where people are worth more than money. To find a credit union that is right for you, check out ibelong.org. And by the Energy Association of Pennsylvania, Pennsylvania's energy information source. This broadcast of Pennsylvania Newsmakers is presented by the Hospital and Health System Association of Pennsylvania, working towards a healthy Pennsylvania.
Welcome back to the program. Well, I'll tell you what, there's probably no more important subject that we could talk about on this program, whether or not you're going to have a physician available to you, and will you have to wait a long time to see your doctor? Joining me is Dr. Bruce MacLeod. He's the president of the Pennsylvania Medical Society. Doctor, welcome.
Thank you very much.
All right, let's start with, before we get into this, I want to start with a basic. We've done programming over the last couple of years. Forget the Affordable Care Act about a doc shortage anyway in certain areas, rural areas, family doc shortage. Give us an overview of, before we get to the Affordable Care Act, is it true that we would probably have had some kind of a doc shortage?
Well, we initially had a physician shortage because of the medical legal crisis. We had docs leaving because of the difficult situation. We've made a lot of progress over the last 10 years in terms of medical legal liability reform, which has kind of stabilized that whole system. So if you look at the data now, we actually have stabilized the number of physicians that we have. The concern is that as we get into the Affordable Care Act and this large group of uninsured patients now are seeking care, will they have a physician to go to? And I think you have to realize there's not a bunch of doctors sitting around Pennsylvania with nothing to do. I mean, we don't have empty offices. So as these patients...
You can't go and get a one-year training for this,
no.
Right? It takes years to get this done.
No, that's one of the benefits about a physician is they take 10 years to get through the system because they're so well trained and the expectations are very high, even higher than they've been before. The whole idea of coming out of medical school and hanging a shingle is really unheard of. I mean, there's a lot of specialization even. even within primary care, gerontology and stuff like that. So I think that there's going to be a challenge, but until you have, it's almost like you have to have a need there. It's almost like a market force.
Right.
If you have to have a demand there, and they'll be coming through.
Yeah, I think that's true of almost any. That's a great point. That's not, I think, been sufficiently made. Okay, so we've got this. There is no doubt that as a result of the Affordable Care Act, we're going to get, and I'll use a number, and we can argue about 9 million more people will segue into Medicaid. And that's going to put huge pressure. There have been reports that I've been reading, particularly in California, where I didn't believe this. A doctor, a primary care doctor, has 26,000 patients. How do you do that?
I think that would be a very, 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 very large practice.
More than a third of whom are on Medicaid.
I think that's in a very specific environment.
I understand, but the point I'm trying to make is that there's going to be huge pressure on doctors, to see patients who are on Medicaid. That's another aspect of it, right?
Well, they're on Medicaid. If they've been seen uninsured already, then these are now people that they will now have insurance.
Right.
So that would be a good thing. So if they haven't been seen uninsured, then they maybe have difficulty fitting them into their practice. So what it will be a benefit to is those practices which have been taking care of the underserved already will be in a better situation.
And that's true for hospitals, right?
Exactly.
That's true for hospitals and docs.
And that's what the hospitals expected, was because of the funding for these uninsured now, is they would be seeing a flow of funds that way. So it would be better for the patients. And those barriers, and I work in the emergency department, I'm an emergency physician, so I see patients that come to me because the system has failed. They can't get their medications, or why didn't you come sooner? I didn't have insurance. You could have called 911. Well, I didn't want it to cost. I see these things all the time. So when these patients now
treat them, you have to treat them under law. But as I say, you treat them. No doctor is going to turn somebody away. Of course not.
Well, in the emergency department, I have EMTALA, which is a federal law, and it is a good law that says, listen, if you think you have something wrong going on, you can get care. And I think that's a good thing for our country.
Absolutely.
That's a good thing. But now you'll have, with these folks that didn't have insurance before, will now be able to go and do the preventive care, be able to get involved in medical homes, as we heard about before. Those are all good things. And if we can do that in an efficient way, I think we'll be making real progress.
Before we run to a break, and I want to pick up on another subject, Medicaid expansion is going to bring 9 million people, some of whom were not seeing doctors before. What is your concern about what that means to your profession?
I think that we welcome the challenge. These are folks that we know that if you try to have health care policy based upon data, and we know that if you have insurance, you're less sick and you die less. So it's good to have access to care. So the key is you have to get these folks in the system, and then now the system, which is very complex, but also pretty pliable, we have to put them in and find out what's the best thing for them to do. One of the things that Massachusetts found is that when they brought in all these uninsured, when they opened it up, these folks were sicker than they thought. The folks that had not been getting care before, and that makes if you think about it for a second, that actually makes sense.
The longer you stay away and you don't see a doctor and you don't get the coverage, I mean, we've talked about that for a long time on this program. We do a lot of health care. All right, when we come back, I want to ask Dr. MacLeod about something called bad debt from the Affordable Care Act. It's something I think that needs to be discussed for a moment, and we'll do that after this break.
This broadcast of Pennsylvania Newsmakers is presented by Highmark Blue Shield, changing the way health plans work for business with a variety of plan options for employers and more choices for employees. Information is available at highmark.com. Have a greater hand in your company's health. And by the Pennsylvania Healthcare Association, the future of long-term care.
Hi, back to our discussion of some important medical topics with Dr. Bruce MacLeod. He's the president of the Pennsylvania Medical Society. Rather than we'll have you back another time. We can talk about this bad debt. I was thinking during the break about we got the Affordable Care Act. There's a huge set of problems with it, no doubt. Whether it structurally works is another matter. Give us get a quick overview of where you think this is all going. This is hugely important to the American people.
Oh, I agree. And I think that my feeling is that we're going to look back at this time and only in retrospect, and the historians will say this, that this was a big change in healthcare and how it's provided. I think it's really going to change. I think that eventually it will work. There's a lot of smart people trying to get this figured out. There's a lot of good parts about the Affordable Care Act that access to, when you're giving access to the folks that haven't had insurance, we believe that's a good thing to do. Patients having access to care is a good thing.
Well, and I've done a lot of polls on it. The voters of our country overwhelmingly support universal coverage. That's not even a debate.
The problem gets to be, well, it's not free.
Yeah.
And someone has to pay for it. And so when you start tapping on shoulders and saying, hey, listen, you're going to have to shoulder some of this burden, I mean, there's a lot of shrugging going on, like, no, not me. And so that's going to be the hard part, because the Affordable Care Act was front-loaded with benefits. Now the piper has got to be paid somewhere along the line.
Yeah.
And I think that, that being said, I think the will is there, because ultimately it's going to be better for patients.
Yeah, one of the concerns that I've heard expressed all the time has to do with the coordination of all these parts, and whether at the end of the day, the young immortals, as I call them, this only works if the young immortals sign up for the coverage. The healthy people have to help support the sicker and older people. I think you would agree with that.
Well, the insurance companies will definitely tell you that. They need them.
Yeah, so,
they need them in the pool.
Yeah, my concern has been, because I spend a lot of time among young people, is, they walk around, what do you mean? If I need something, I'll get it. If I don't, I'm not going to bother.
Right.
So whether that works or not, that's part of the model that, whether we should have just expanded, my thinking was, let's take Medicare because it worked. Maybe we need to tweak it and have it means tested.
Right.
Drop the age, take Medicaid, change the poverty levels. We cover a lot of people that way, instead of this.
You were the sandwich mentality, just kind of squeeze the sandwich right in the middle.
Did you ever think of that?
Oh, I'm sure. No, you're a smart guy. I'm sure a lot of people thought about it, but they ended up on this. They ended up with this, and I think that
it's here, and we have.
Let's
and it
make
has
it
to
work.
Yeah,
I mean,
agree
I think there's smart people. We have a little box. Let's make it work and fit it there. I think that we have an opportunity to kind of see what's the best way to implement this coverage for insurance. And we have states which can serve as little petri dishes. Is it an expansion of Medicaid, or is it to expand the insurance market to do that? Let's see how it works. There's really no right answer for that right now. We don't know what's the right answer. It's worth trying in different. I mean, as a, inside every physician, if you open them up, there's a scientist and a very idealistic medical student inside. And so the scientist in me wants to see us try this as almost an experiment in public policy to see which way work. Where do we get the best outcomes as we expand these programs?
Yeah.
We don't really know the right answer right now. We have ideological directions that we're choosing, not necessarily driven on public policy.
Yeah, I mean, first of all, I want to thank, this has been a wonderful update. I mean, I think we just don't know yet where it's all going to go. I mean, we'll have to see. I mean, everybody has to hope that it works. All right, we'll see you next week for another edition of Pennsylvania Newsmakers, and as always, stay well.